I just want to give like a very fast introduction. I want to welcome you all for joining us again today. And thank you, Professor Karl, for joining us today as well for this session. For everyone who is joining, this is our second session with Professor Heneghan and our second session on systemic reviews. So thank you so much again for joining us today, and I will give the floor to you.
Thank you very much. Just making sure you can see my slides. That look okay?
Yes,
All
we
right.
can see them.
Hey, well, welcome everybody. Thanks for joining us again. I'm sorry about the slight delay in the timings. You should have access to two papers today. One is a PDF of a Lancet paper, which is, we're going to use that as an example of how to look at systematic review. And that's one on self-monitoring of oral anticoagulation. And we're also going to look at the grade system. And then if we've got time, we're going to think about how you might put together a protocol for a systematic review. If you get inclined, I'm hoping that what will happen out of this is, as we discussed last time, we talked about what is evidence-based medicine about, what type of questions you might have, that you might consider being active in doing a systematic review. So, just to remind you, the integration of the best available research evidence with clinical expertise and patient values is the definition of evidence-based medicine. And we're going to think about learning outcomes for systematic reviews today. We're going to look about critical appraisal, because that came up last week where somebody was jumping ahead and said, how do we appraise a systematic review? Look at the outcomes, how do you put outcomes together? And then think about the relevance and application of published systematic reviews to clinical decision-making. And hopefully we'll think about some little tips about putting together a protocol. Okay, so the scenario today is the opening scenario is Mr. X, could be any name, Mr. Smith, 50-year-old father of 5 children. He's recently had a heart valve replacement and requires lifelong warfarin. Well, you'll have used it all about your clinical and basic medicine and physiology and pathology and all of this, and hematology is the clotting cascade. But importantly, thinking about how drugs act in here, there are different drugs that can act, like low molecular weight heparins acts at factor 10A, warfarin acts in different areas, 2A, 8A, 9A, and 10A. And then you've got the newer drugs, direct thrombin inhibitors, that actually don't require monitoring. But actually, warfarin's an important drug. But thinking about what types of conditions might you use these different ones, heparin, warfarin, factor 10A inhibitors. Well, actually, there's a range of different. So immediate anticoagulation, we often use heparin for all sorts of PE, stroke, and even in pregnancy. Warfarin, we're thinking more about chronic anticoagulation. We still use DVT treatment and prophylaxis, but particularly in heart valve damage and atrial fibrillation, we've still got a lot of older patients in, but in more patients are going on factor 10A inhibitors, but that's for DVT and PE and atrial fibrillation because it doesn't have the more monitoring. But in heart valve damage, there's still a need to use warfarin. Now, one of the key things about warfarin is its therapeutic index. It uses in INR, the international normalized ratio, where what happens is if you use warfarin, if you make the blood too thin in a simplistic way, then the INR above 3.5 increases your risk of intracranial hemorrhaging, increasing your risk of bleed. But actually, if the INR is too low, it increases your risk of a thrombosis and a stroke. So you have to maintain warfarin within this normal range. So for atrial fibrillation, it's about 2 to 3. But actually with heart valves, it tends to be a bit higher, 2.5 to 3.5. But when you can see you go outside of those norms, you see the risk of thrombosis or intracranial hemorrhage suddenly increases exponentially. One of the key aspects about warfarin is this issue of time in therapeutic range. So when you have a warfarin and you have your test, it might say in the last 6 weeks, you were in range within your 2 to 3 INR. If that was so, that gives you 100% in time in therapeutic range. And you can see what happens is there's a very different cumulative survival dependent on the time in therapeutic range. So here, when you're down at 30%, really poor survival. Now, importantly, you want to think about ways to ensure that individuals, when they're on warfarin, improve their time in therapeutic range. One of the ways you can do that is with a point of care test where individuals self-test themselves. And there are two strategies they use. They can self-monitor and communicate with a healthcare professional who gives them the advice on what to do, or they can self-monitor and self-manage. So they actually learn to adjust their own dose. And you can see here the test strip here, the INR's 2.7, which would be in range. So this is a way of handing over the care to the patient so that they're empowered to make decisions. The question is, what does it do? How does it perform compared to usual care, usual monitoring, clinic-based monitoring? And that's where you want to go and find evidence, where you go to the top of the tree. And what we're looking at, the increasing strength of evidence, the quality, is we're talking about systematic reviews and meta-analysis. In doing that, let's think about what is a systematic review. Important definition. The systematic identification, appraisal, and synthesis of the evidence from studies addressing the same research question. Now, what we like to do is give that a very simple acronym based on a clearly formulated question. Identifies, finds all the relevant studies. F, appraises the quality of studies. That's the A, and summarizes evidence by its use of explicit methodology. Now, if you've got question, find, appraise, summarize, you've got the very clear basis of a systematic review. So if a review asks a clear question, but doesn't try to find all of the evidence, it's not a systematic review, it's a review. If it has a clear question, finds all the evidence, but then doesn't appraise the quality, it's not a systematic review. Now, there are different methods to summarize the evidence, but actually these bits have to be, all the elements have to be there to make it systematic. So here's the QFAS. Is there a clear research question? Did they find all relevant studies? Did they assess study quality? Did they summarize the evidence, and does it make a difference is the point. Now, that's your QFAS to remember when you're thinking how to quickly go through a study. Now, what I'd like to do here is to go into the clear research question. Well, you know how to do that because we did it last time. It's very clear. You operate a PICO, population of interest, the intervention, the control, and the outcomes. Now, when we do that, it's quite interesting, isn't it? You've got to be thinking in unstructured questions for what, for whom, compared to what is meant by effective. So be very clear, you put together, do adults, that's the population, using oral anticoagulation therapy have fewer episodes of thrombotic events if they are self-managed than those that are managed by their doctor health professional. So that's a very clear PICO that you could have changed the outcome to hemorrhage. You could have been more specific, do adults with heart valves using oral anticoagulation, but you have a very clear PICO that you put together, and that should be within the systematic review. So now I've sent you the copy of the paper, the PDF. I'll just give you a few seconds. You might want to open this, or I've got most of the bits coming here very clear on the slides. But this is a self-monitoring of oral anticoagulation, systematic review and meta-analysis, which was done by our group and published in the Lancet. Now, here's the background. Near-patient testing has made self-monitoring of anticoagulation with warfarin feasible, and several trials suggesting that such monitoring might be equal to or better than standard monitoring. Therefore, we did a systematic review and meta-analysis of all randomized controlled trials that they assess the effects of self-monitoring or self-management. Now, look, that's a clear definition. Self-tasking and self-dosing is self-management, whereas self-monitoring is you take the measurements and communicate with a health compression. And you're comparing that with standard monitoring. That's our PICO. So that's step one. We've got a clear question. Step two, how did they find the studies? Which databases were searched and how many? You could look at the paper. Was the search specified, the timing? Was grey literature search? Did they contact study authors? Did they search bibliography? Your basic question is trying to say, to what extent did they do a comprehensive job of trying to find all the studies? So you want at least a minimum of 2 databases. You want an approach, which is a grey literature, to try and find unpublished studies. And then you do things like search the reference lists or the bibliographies to check you haven't missed anything. And when you do that, you basically think about what type of studies were included, how many were eligible, how many were excluded, what were the reasons for exclusion, is there a list of exclusion studies? And also, if we disagree, how do we resolve those disagreements in the method? And when you do that, you come up with this flow chart, which is a flow chart of the studies. Where did you start at the top here with 345 relevant records? This is not bad because this is a low number for a systematic review because you've got the RCT filter and it's a very specific technology that you can search for. We've had systematic reviews where that top line figure can be up to 10,000 because it's a much vaguer question. But what you see here is a flow of the papers to end up with 14 randomized controlled trials included in the systematic review and meta-analysis. So that's the find. You've got a clear question, attempts to find. Then your third is, how did they assess study quality? Well, here you'll see that actually we had 5 strategies: method of randomization, allocation concealment, blinded outcomes, intention to treat, and follow-up rates. And if you were listening in the last lecture, you'll realize that's assessing the quality of the individual randomized trials. In addition, we did something else called a sensitivity analysis. So basically, what you might do is if you find an effect, you remove the low quality studies to see if the effect is robust to removing the lower quality studies. If it is, you might say, actually, this effect is not affected by the quality of the evidence. But if the effect is removed, you might say there are some issues with bias in the trials that actually undermine the treatment effect. Now, that's your appraisal. So I moved very quick through. I'm going to slow down a bit now because we're going to look at the basics of meta-analysis. This is looking now at the outcomes. You've got 14 trials. You're going to use a meta-analysis which combines data from individual studies and presents the results in a forest plot. It can use 2 different types of effect, a fixed or random effect model. You can test for variations in trial designs and participants. That's called the heterogeneity. You can test for publication bias, funnel plot, and as per usual, whenever looking at results, you should still interpret it with some level of caution. So it's a way to calculate an average. You basically are taking all 14 studies and bringing them together to produce a pooled analysis. And actually what you do is it estimates an average or common effect. And if you think about it, it proves the precision of an estimate by using all available data. Many trials are underpowered, but when you bring them together in a meta-analysis, you've got the potential then to improve the power and precision of the estimate. It's an optional part of a systematic review. Not all systematic reviews have a meta-analysis. Not all meta-analysis are part of systematic reviews. So the fact is, if there is or isn't a meta-analysis, that doesn't still define it as a systematic review, but it's an important one for quantitative analysis. Now, here's figure 2 in the paper. This is self-monitoring and thromboembolic events from a fixed effects model. Now, basically, if you look at this, it looks a bit, some of you may have seen this before, some of you may be happy with this, but we're just going to walk slowly through it. First is at the bottom, there's a horizontal line. This basically line is measuring the treatment effect. It's important to know which way round it is. So to the left favors self-monitoring, to the right favors control. Important to check which way round it is. The vertical line in the middle is where the treatment and control have the same effect. There is no difference between the two. So there's a vertical line going up the center. Now, for each study, there's an ID, often the author's name with the year. The data for each trial are here divided into the experimental group and the control group. And this is the percentage weight given to the studies in the pooled analysis. And then at the top is the label above the graph tells you what statistic has been used. And the data are also shown in the graph, are also given numerically. So this tells you, for instance, this is an odds ratio. This is the average effect, the mean effect, which is here represented by 0.30. And this is the confidence interval, which is represented by these lines. Now, the pooled analysis is a diamond shape where the widest bit in the middle is located at the calculated best guess, the point estimate. The horizontal width is the confidence interval. Now, importantly, if the confidence interval crosses the line of no effect, we have found no statistically significant difference in the effect of the two interventions. Whereas here you can see it doesn't touch the line. So, just to recap really simply, thinking simply about this, when you look at it visually, you can tell what's going on. You've got the number of trials, here there's 3. You've got the confidence interval, the arms of the confidence intervals. You've got the line of no effect, and you've got the overall effect. And you can see it's that simple here in our house. I have my girls doing forest plots as part of their homework. So it's actually a really simple way of looking at it. And here now, when you look at this, you can start to see simply, what can we tell from this graph? Well, what we do when we look at it, make a very simple summary by working your way around it. There's 14 trials. It's important to do. We can see down here, it's significantly reduced thromboembolic events. The odds ratio is 0.45, 0.3 to 0.6. It doesn't touch the line of effect. This effect was significant in those who self-adjusted, that group there, and in those who self-monitored and self-managed, So in the self-adjustment, that's a self-management group, and the self-monitoring. You can see, though, in the self-adjustment, self-management, the effect is greater than what it is in the non-adjustment, the self-monitoring only. Now, importantly, only 10 trials provided information to calculate the effect size, because if you have no events, none of 23 and none of 26, it can't calculate an odds ratio. But you can also see, if you look at the events, the trials, it's really interesting. Only one trial was significant in its own right. All the other trials crossed the line of no effect. Now, the key is they were non-significant, but you can all see, apart from one, they were going in the same direction. So again, you could look at this one, which is the major hemorrhage. You would look at the major hemorrhages and see what happens with them and give a summary again. 12 trials reported on major hemorrhage outcomes. 10 provided information to calculate the overall effect size. Self-monitoring was associated with a significant, I've just put it in layman terms, 1/3 reduction in major hemorrhage. In the studies of patients who self-audited only, there was a significant reduction. Yeah, that's this group here. But if you look at the self-monitoring and self-adjust, then actually there was no significant effect. But we also test for this interaction. This is like a little bit down with something called a subgroup interaction, and that wasn't significant. So it suggests that there isn't a key difference between the two statistically, but if you visually look at it, it looks like that. Now, also what you can do, you can test for publication bias. This is the funnel plot where you're testing, looking at either side of the odds ratio to see what it looks like in terms of you can examine publication by constructing a funnel plot. What you're basically seeing is either side of the effect size, do you have positive and negative studies? Now, I'm just going to move on. So we didn't stop there, because not only did we publish that, we published updates in the Cochrane Library of the same review. Remember, I said there was 14 studies, but what the Cochrane Library does is it was named after a British epidemiologist, Archie Cochrane, who was a great advocate of randomized controlled trials to inform healthcare practice. It's got over 5,000 reviews registered, regularly updated, focus on interventions, and it's an outstanding general resource. Now, one of the key issues here, just having a recap, is the logo itself. If you look at it, this is a Cochrane logo, is actually a forest plot. Now, if you look at that, there's 4 questions. I'll just give you a second to think about them. And then just consider, How many trials are there? How many trials are significant? Which is the trial with the most precise estimate? And is the overall effect positive or negative? So, how many trials are there? Well, actually, it's quite a straightforward answer. 7. How many are significant? Well, actually, if you look at it, only about 2. Which is the trial with the most precise estimate? Could be that one, probably that one. Is the overall effect positive or negative? Now, if you answered positive or negative, you were wrong, because the problem is we don't know. Because if I said you had to read which way round here was the measurements, which was positive, which was negative, and without the legend, we can't tell. But actually, that's the forest plot of dexamethasone in preterm infants for respiratory distress. And actually, one of the first most important systematic reviews that showed dexamethasone for preterm infants has an impact on respiratory distress. This is the funnel plot, as you can see in this systematic review. Now, one of the key things why it's a funnel plot, you can see that actually there are outcomes both sides of the lines, which is reassuring. If you had publication bias, you might only see many studies here and some of these studies missing. So visually, it's a really helpful tool to look at whether you've got asymmetry and therefore you might have publication bias. Within the Cochrane review, what they do is have a risk of bias summary. This is the review author's judgment about each risk of bias item. And as we say, the 5 risk items are random sequence generation, allocation concealment, intention to treat, reporting of losses to follow up, and blinding. And each one, green is that's an okay, red is a risk of bias, so that's low risk, that's high risk, and that the question marks are unclear. Often that's there because it's not been reported in the paper. Now, one of the things I talked about just down here is, you will look down here, is heterogeneity. And here you can see that the I-squared is 0%. What that means is these statistical tests are all providing a similar outcome. And you can visually see that because they're all lined up. They all line up as you go down and all overlap each other. But if they were wildly different results, either side, for instance, of the line, then the heterogeneity would be increased. And you might ask whether there's issues about whether it's robust to combine these trials. Often, as a rule of thumb, an I-squared above 50% is often concerning and should be investigated. Now, in the Cochrane, and this is just a way of summarizing the risk of bias, which gives you the green is a low risk, unclear, and the rest is high risk of bias. And that's what review author's judgment about each methodology quality. And it's a nice summary that you can see actually down here. Blinding is a real issue. More than half the trials were either unclear or high risk of bias. Within a Cochrane review as well, you get these grade tables, which allow you to look at the assumed risk and then also calculate the corresponding risk. So here, if you look at thromboembolic events, you take a study population 35 per 1,000. Here they talk about a moderate risk, which is a bit less. And then what you can do is take the odds ratio and calculate a corresponding risk. So you go from 35 per 1,000 down to 21 per 1,000. And that's your absolute risk reduction. So for every 1,000 patients who self-monitor, you'll get about 14 fewer thromboembolic events. And if you think about that, that's 14 fewer strokes, which is important. And importantly, you don't see any increase, because you see it just crosses over the line now, in all-cause mortality. You get less thromboembolic events and low strokes, but not quite significant for mortality. Now, importantly, at the bottom of the table, you'll see there the grade working group grades of evidence. What it tells you is, here's just simple definitions. What does high quality mean? Well, we are very confident that the true effect lies close to the estimate of the effect. In effect, that this result, this outcome, we consider is true based on this evidence. But if you've got very low quality evidence, we have very little confidence in the effect estimate. The true effect is likely to be substantially different from the estimate of effect. And so these grades here are moderate. So for major hemorrhage, it's moderate and it's moderate means we are moderately confident in the effect estimate. Okay, but there's a possibility it's substantially different. Now, one of the things we've been through a whirlwind tour of systematic reviews, and one of the key issues is grading the evidence. What does that mean? And this is something I've sent the paper with that the World Health Organization use when they're thinking about guidelines. They use grade to look at the evidence, grade tables. And I'm just going to show you what we do at the WHO in setting recommendations. So it's used for appraising control study, separates quality evidence from strength of recommendation. You want to make a recommendation about the use of self-monitoring, but you also want to say it's based on the what strength of evidence. You assess the quality for each outcome, and you can upgrade observational studies or downgrade randomized trials. Is paper in the BMJ, which is a useful one. Gaia et al., published in 2008, is a helpful paper. It's freely available. Now, 5 distinct steps. You sign a priority ranking of high quality to randomized controlled trials and low to observational studies. Downgrade or upgrade the initial ranking of the evidence. Step 3, assign a final grade as high, moderate, low, or very low, which we showed you. 4, consider other factors that impact on the strength of recommendation for a course of action. Make a strong or weak recommendation. You can make a conditional recommendation. So what do we downgrade or update initial ranking of evidence? Okay, so you can upgrade for risk of bias, inconsistency, imprecision, indirectness, or other considerations. 5 items. Well, we talked about risk of bias. You've now 2 lectures where you're starting to imprint of the features that affect the bias. So if there's lots of bias, you downgrade the strength of the evidence. Inconsistency. Now, I talked about that. Heterogeneity. If there's significant unexplained variability across kind, consider downgrading if heterogeneity is high and cannot be explained, so if it's above 50%. You might see heterogeneity, for example, because in some trials you used a higher dose compared to other trials where they used a lower dose. Well, what you would do is repeat your analysis and separate those 2 out and see if that explains the heterogeneity. Imprecision, that's about the width of the confidence intervals. If the confidence intervals are wide, downgrade, upgrade if there's narrow, if there's a precise estimate. Indirectness. Now, that's important, and this is often important when the evidence you're looking at doesn't apply to the population you see. So when you're in your populations, you might be seeing, well, actually, this evidence is developed in America, and we're trying to apply it in the Middle East. Well, that actually, you think about that thinking, does that downgrade because it's indirect evidence, and particularly if surrogate outcomes are reported instead of hard outcomes. 5th, then, just to consider other considerations, publication bias, reporting bias, magnitude and relevance of the outcome, and as I said, this important thing, dose-response effect. All of these are very important. Is it an important clinical outcome? Is it that there's a dose effect? And this is often important for observation studies. Now, you assign a final grade to the evidence. High, moderate, low, or very low for all the critically important outcomes. When you do that, I've just gone through these. High, we are confident, going right down to very low, we have very little confidence. And so there's a grade about the confidence in your evidence. Now, step 4 and 5, other factors that impact on the strength of recommendation, and then make a strong or weak recommendation. So here's the other factors. So this is a decision tree we use. Uncertainty about the balance of benefits versus harms and burdens. They may not report the harms. You may not be aware of them. If it's lower quality evidence, uncertainties or differences in values. Important, what do stakeholders think about the outcomes? Are they all the important outcomes? Now, also you might downgrade if uncertainty about whether the net benefits are worth the cost. Thinking about the resources required, how much money will it cost you? Is it sustainable or all important? Frequent yeses increase the likelihood of a weak recommendation. Now, here's the implications of a weak recommendation. The majority of people in this situation would want the recommended course of action, but many would not. Clinicians should be prepared to help patients make a decision that's consistent with their own values, decision aids, and shared making. There is a need for substantial debate and involvement of stakeholders. This is particularly important at policy, particularly given how much resources, how much will it cost. That's the corollary, is if you make a strong recommendation, then most people in this situation want the recommended course of action, and only a small proportion would not. Most patients should receive the recommended course of action. It can be adapted as a policy in most situations. So basically, if you've got high quality evidence and you've considered the other factors, you're looking at this in terms of, should this be a strong recommendation? That's important, following through from policy to clinicians to be able to sign a course of action. Now, one of the things here on our website, we have all of these critical appraisal tools, which are freely available at CEBM. We are going to be translating some recently. And I know we've got some student in Egypt who's maybe going to have some translations later on this year available. So they're in various languages, but they're all freely available, which allow you to do a systematic review with the sort of QFAS acronym, giving you the hints, particularly the yes, no's, and in clear for each thing. Now, what I'm going to do now, I'm going to take take some questions now, if that's all right. And before we think, because that was a whirlwind tour of systematic reviews, before we then think about whether you might, and we'll go through a protocol, but I'll just take some questions for now. Any questions out there you want to put in the chat or anything? Let's give you a minute. Or is everybody happy?
I think some people have done the task, like they told us in the group chat that they did. So if anyone also wants to share that with us, feel free to do that. I'm talking about the clinical question that Professor Heneghan asked you to.
Yeah. So thinking about in the context of a systematic review, you might want to do, has anybody got a question or anything they want to prepare?
Okay, yes, we have a raised hand. Muhammad Masauda, go ahead.
Hi, Doctor. I'm Muhammad Masouda, and my friends Muhammad Ali and Muhammad Zawara have a big question. Talks about what is the effectiveness of glucocorticoid therapy compared to placebo in reducing symptoms in patients with arthritis. The PICO population are patients diagnosed with arthritis, and the intervention is glucocorticoid therapy, and the comparison is a placebo, and the outcome is reduction in symptoms like pain, joint inflammation.
So let's just go through that slowly. So your arthritis and
glucocorticoids compared to placebo.
Okay. So that's your question. Yeah?
Yes, it's a PICO question, yes.
Yeah?
Yes.
Now, one of the things about I'm just going to share my screen, okay? I'm going to share my screen again because we're going to do this in real time, okay? All right, can you see I'm just going to take this. Can you see my full screen?
Yes.
Mm-hmm. Yes.
So just as you would see speaking, I put in rheumatoid arthritis and glucocorticoids. That's your patient P and that's your intervention, yeah?
Yeah.
Now, one of the great things about PubMed is it's freely available. We get 7,977 results. We're not going to go through them. But one of the nice things here is if we put the filter on, yeah, we put the systematic review feature, we get down to 94 papers immediately, okay?
Mm-hmm.
Now, what you'll see is there's a there's a whole host of systematic reviews here that have been done. So it's obviously a topical question that you could go and apply the QFAS to. So first off, it's not difficult if you use this structure to find the evidence. Yeah. Now, the question is, what you're trying to do is say, to what extent is this known? Is it up to date? Is this sufficient to answer my question? And here they even got tapering low dose in patients with RA. So I think you probably find this is a systematic review that's been covered. You can go and look. Now, the question is, you might say in your population or in certain areas, there may be a dearth of evidence. Then you could narrow the PICO down and be able to look at that in that way. So use PubMed to plug in your PICO, using the and to combine them, but then go down the left-hand side like I showed you for the systematic reviews filter, and then quickly you can go from 7,000 plus papers down to less than 100. Well, that's actually manageable then to be able to find the evidence you want. Now you can plug in the QFAS to the systematic review you want to look at. And that's what I would do. And that's a really neat way then for you to be able to say, right, what was the question? What were the find? What's the quality of the evidence? And how did this summarize the outcomes? And and if you can do that really efficiently, the hardest step is doing the bit which we just did. You formulated the question and getting down to the evidence. Somebody else has a go. We can have a go, keep going in real time, because that's the real skill. And you've got access to PubMed, haven't you? In your yeah.
Yes, I do.
Yeah, perfect. So have a play with that and see where you get to with that. Got another raised hand then.
Yes, we also have Duha. Duha, you can go ahead with your questions.
Hello, doctor. Thanks for your time. My bigger question is, in pediatric patients with Down syndrome, how does the endurance management strategies and long-term outcomes of hematomas compared to those in pediatric patients without Down syndrome?
What was is this about a prognosis question, or is it about I got you Down syndrome pediatrics, and what was the exposure or intervention, sorry?
It was the relationship between Down syndrome and hematoma.
Hematoma.
Yeah.
Interesting. Why is that of interest to you?
Down syndrome was one of my interests. I want to in the future do a lot of research on Down syndrome because I believe there is a solution and we can actually treat these patients and turn their lives back.
Okay, interesting. So look, let's go again. Great evidence-based question. Let's see if you can see that. You can see we're into PubMed again, yeah?
Yes, sir.
You can see, you don't have to call me sir, you can call me Carl or Prof. Either one's okay, right? Down syndrome and children and hematoma. That's what you're interested in, isn't it?
It is, yes.
So we've got 2,890 results. Interestingly, you can look and see here, this is neat sometimes to see what's going on in the literature. You can see not very interesting, and actually you're jumping on something that's become interesting in the last 10, 15 years, haven't you? So there's been an increase in publications in the area, but that's a helpful bit to understand. So you can limit it sometimes if you want, very simply by just pulling across and saying, well, I want to know what's going on in the last 10 years. So you can take 2008, still a lot of results, okay? So you can do that, but we can also see what's going on here in the systematic review world, okay? Now, actually very much less in the last 10 years, okay? A lot less, and not all of it is myoclonation, adult children with celiac nation with Down syndrome. So we haven't got time, but that's a neat way. Now, if you find your question is not addressed by a systematic review, but it's addressed in this 2,900 results, yeah? you have found the potential. So let's have a look at how many observational studies are. Oh, there are 19 studies. Yeah. So there's lots of interesting stuff here. Yeah. Outcomes of patient with acute leukemia and diet. So we can't go in, but what I'm saying to you is do it as a filter with the levels of evidence. So start in PubMed, you can limit the years if you want, but go for the systematic review. In the first question, it was very clear there were systematic reviews that praise the quality, but in your scenario, there may not be one. Then you go back and look at the original studies, and then you are in the ballpark of, have I got the potential to do the systematic review? You've identified a research need, a met need, and that's where you start to think, this would be a really interesting question to do a systematic review on. So you do it in
Yes.
that filter, that way. Do you see what I mean? Look for the systematic review, praise the quality, then think, oh, but in your situation, you might not find one. Then see if you've got sufficient studies that can be of observational, because likely to be observational, to do the systematic review. Then find some friends to help you. Okay.
Thank you, sir. Thank you so much. I really appreciate it.
Yeah, just you don't have to call me sir though. I'm not okay. You can call me Carl or Prof. One or the other is okay.
All right.
And look, being active is the main thing. If you want to do research, think about doing the systematic review first. Why? Well, look, I meet loads of researchers who go off and about 5 years down the line, they say, oh, I've started to find all these studies about what I wanted to do, and I've been wasting my time. Whereas if you do the systematic review, you are basically saying science is cumulative, therefore I should accumulate scientifically. So if you do the systematic review, you'll be able to say what methods have been used, what do we know, but also importantly, what we don't know, and what are the gaps. And that's what your research will address, those gaps. Now, I would start probably a little bit broader and just say, if you're interested in hematomas, you might think about just what are the outcomes of Down syndrome children and hematological outcomes, and check whether hematoma is the biggest one or are they actually other ones, and in what specific conditions. Like there we had some leukemia, infection. Is it in certain condition makes it much worse? And then you start to narrow in your focus. Okay. Because you'll find some areas, oh, got lots of evidence there. Some areas we're missing. All right, good. Got lots of hands up.
Yes. So I think Zaina YMCA, since we have two Zainas, I think Zaina EJ, you're the first one who raised her hand.
Yes, this is me. Good evening, Professor. Thank you for your time.
Yeah.
So I've been working on this research topic for a while now. It's been one of my interests, and I've recently known the PICO system, and I've broken down my research, which is talking about deep pressure therapy and as a treatment for autism spectrum disorder. So I've broken down my subject into the PICO components, which is the patients who will be children with autism, and the intervention will be deep pressure therapy, for example, weighted blankets or weighted vests. And I would compare it to no intervention, or I was thinking on, still not sure about it, on standard educational support. And finally, my outcome would be of course, reduction of anxiety levels and any other behavioral issues.
So just spell me out how is it pressure therapy or depressure?
Deep pressure therapy. It was an idea from Professor Temple Grandin. She's a autistic professor also. She's known for this intervention. She created it using the squeezing machine.
Okay, so I know lots about autism, but I know nothing about deep pressure therapy. So that's the component of evidence-based medicine. But immediately, again, I'm into our interesting bit, and I'll start with actually children and autism, and the reason is because when I put deep pressure therapy, it's coming here and showing pressure therapy. Because deep pressure therapy achieves no results, whereas pressure therapy does. Yeah. Now, you can look at what pressure therapy is. That might be something. Deep pressure is the opposite, I assume, of pressure therapy. Or I don't know, but if you're in a brand new area, you're in the epidemiology of discovery. Yeah. That's different to the epidemiology of decision making, where we're saying, what are the established treatments for autism? If you're in the discovery, what you're trying to do is develop a very clear pathway to getting to the epidemiology of decision making. So you're basically going from small observational studies, trying to work up the sort of feasibility study to say, to what extent is this intervention feasible? Is it deliverable? And can we actually test it? Now, one of the things I'm going to do here, is you're in the what looks like a complex intervention. Yeah, it's not a simple intervention like a drug, is it? It's complex. Is that fair enough?
Mm-hmm. Yep.
Now, have you ever come across the MRC framework?
Yes.
So I think you want to really think about. I have DPhil students who basically, when they're doing it, it is available, I'm just in it, is basically use this framework to very clearly set out the steps of what you're doing. And here's the core elements here of what you're doing in this framework for developing and evaluating complex interventions. And it's very helpful, yeah, because you've got the core elements of what you're doing, you've got the feasibility, you've got the development and identifying, implementation and evaluation. So I would recommend, oh, so I didn't want that, is that framework and use that framework. So if you was doing a DPhil with us in Oxford, I'd expect you to start right at the beginning and say, my development of an intervention is embedded in what framework?
Mm-hmm.
We use the MRC complex framework. And it has things like identifying the theory, testing the intervention, testing the feasibility. And it's a very good framework for taking forward your research.
Thank you, Professor.
Yeah.
We have two hands raised. I think, Muhammad, you raised your hand first, if you also have a question.
Yes, hello, Professor. My question to you is, how do you know is it a good idea to write a systematic review about a specific subject or not? Does the field need this systematic review or not? Is there any steps to run just to know that no, it's not a good idea to write because there are a lot of systematic reviews, or no, you need to write, or the systematic reviews are old. So how to know that?
Well, I guess we've shown that. I mean, it sounds like if you've got your question, once you start to learn the skills of plugging it in like I do in PubMed, as soon as I'm listening to you, I'm trying to hear the Pico. Now, everybody else, if I was a bit like, I didn't hear the Pico. So I'm like, what's your question? And as soon as I've got your question, I start to go, right, what's been done? And I use that framework, that triangle, the pyramid, and say, right, start right at the top, work my way right down. What systematic reviews have been done? What RCTs have been done? Particularly thinking of the PICO. So I might find examples of PICOs, which actually we go, well, okay, it's been done. We think it's been done, but actually, there's actually not been done in this population. So once you work your way down, you'll see the gaps that exist in the literature. Yeah. Yeah. And so there's lots of gaps where you can think about what's going on. And so for instance, if you wanted to do a systematic review of the prevalence of obesity and factors, you'd probably say that's been done. But actually, if you suddenly say, well, actually, I want to do it in Palestine or somewhere very specific, you can very quickly start to see, you can find studies like this, which are very specific populations. Gaza Strip, Palestine. You've got healthcare workers. You've got a very different population than to US healthcare workers, for instance. Now, what you can also do is use this similar articles and see, oh, actually, there's quite a few here. It's in children as well. Actually, what do we get? How many have we got? Have we got enough to be able to think that a systematic review can be very specific population? Well, actually, in specific populations, things like exposure to obesity and outcomes can be a much more useful systematic review when you say, I'm going to narrow it right down to this population. And even if you only have 5 or 6 studies, that's really helpful. Much better than saying, I've got 50 studies all around the country, but they don't really apply to my population. So I think a lot about that, levels of evidence coming down the triangle, seeing if there's a gap, but also there may be gaps with specific population.
So the key concept is just to have your question, then running the PICO. Then even if there are a lot of research about this specific subject, you can manipulate some variables in the PICO to fit your question, to fit, or let me first to close any gaps in the field.
Correct. So that's exactly what we did with the Down syndrome. Start much broader, right? What do we know about Down syndrome and hematological consequences, outcomes? What systematic reviews have been done? I often do a little spreadsheet for myself and say, right, here's these 10 systematic reviews, and each column I put a little PICO in, right? This is in children, this is the exposures, these are the outcomes, what was the date? I do that, and then I go, right, is there a gap about hematomas? If the answer is yes, I go, right, well, you'll do that systematic review. If there's no gap, I'll go and appraise the quality and say, to what extent does this help me? Now, if there's a gap because you can say, actually, I could do a better job just by looking at children in Palestine or in the Middle East, because it's more applicable to my population. Actually, we need lots more reviews like that. And for instance, I'm doing a systematic review at the moment, and we've realized it's about multimorbidity, 2 or more chronic conditions. And actually, we've realized that actually it can only ever be UK specific. There's no use in doing a systematic review outside the UK. Definitions are different, how we treat people, the general practice, how it's organized. So if I say these are the outcomes and I'm comparing US to UK, it's not, I can do that, but actually I need separate systematic reviews. So that specific sometimes is really helpful.
Okay, understood. Thank you, Professor.
Okay, so I don't know, we are already like if we have time or not, but we have one last question.
Yeah, let's have the last question.
Okay, Zaina Isa, if you want to ask your question, go ahead.
Hello, my friends and I have been researching the extent of the functionality of 3D printing in the medical field. So we found an article about the reconstruction of craniomaxillofacial trauma and how we can incorporate 3D printing into the process of that. And we came up with a PICO question of, in patients with craniomaxillofacial bone defects, how does 3D printing technology compare to conventional methods like autologous bone grafts in terms of functional and aesthetic restoration, surgery time, complications, preparation time, and costs?
Okay. So interesting. Let's see if this works. Okay. Oh, this is really interesting. Like, just bear with me. As you're talking, I'm typing. Okay.
Okay.
So, it's very interesting. Look at this. So this is just 3D printing, which comes up as a mesh term. So it's an important term. Look at what happens. Oh my gosh. So yeah, it just follows the technology, doesn't it? Nothing happening, a little bit. And now you're going into an area where you go, oh my gosh, look at this, 5,000, 5,500 a year. So you're obviously in an interesting area. Yeah. As you were talking, I just added craniofacial. Look what happens. We go from, oh, sorry, 3D printing. We go from 31,000 results. We just put it in craniofacial and we come down right to 385. So I wouldn't search and add in all your bits, okay? I start to build it little bit by bit on the search. And then basically, if we put the systematic review filter on, okay? Oh, sorry, I didn't want that. Wrong filter. Systematic review filter. We actually get down to 8 systematic reviews. And there you go. Actually, there's somebody there in February 24. Very interesting. And now you could do a QFAS, look at that and see what's going on. See what populations they were done in. Yeah. You've got craniofacial reconstruction. So sometimes we do a little overview of reviews. We say, right, what do we know from these systematic reviews? But basically, this is really helpful. You can get the full text. And then think about 5 studies, how many studies were there. See, screening 120 articles. You can start to build your QFAS really quickly. So A, you're in a really interesting area. B, you can find what's in the systematic reviews. If you think about the grade, it may be the outcomes are really interesting and important, but also think about those grade things. Often you've got to think about the feasibility, the applicability. What resources do you need? What's the cost of it? What's the training? So sometimes you might go in a systematic review and think, geez, there's a lot of really unanswered questions here that don't help us apply intervention. And so I think that's a really nice one to go and look at one of these systematic reviews and see if you can extract. First, do your PICO, your critical appraisal, but think of the grades, the other issues. How do we apply it? Can we afford it? Now, then think, does this apply to my population? If not, you may have to rerun your own study while you develop the technology.
Thank you.
Yeah, very interesting.
Thank you.
Thank you so much,
You're
Professor
welcome.
Heneghan, and thank you everyone for joining and for also being interested and actually asking questions. I hope you learned a lot. I know that I did. So thank you again, Professor Heneghan,
You're
and we
welcome.
send the feedback form in the chat, also in the WhatsApp group. So make sure that you fill it. And we will see you in our next session on the 1st of August. So thank you again and have a nice evening, everyone.
Good luck, everybody.